Hello everyone, I am Dr. Shoham Mukherjee and welcome back to the channel. So today we are diving into the OBGYN Ultra Rapid Revision Part 1, which will be Obstetrics. All the most high-yield topics for FMG and NEET PG covered in just 4 pages. So this is your last minute lifesaver, fast, focused and super effective. Only what's truly important, no fluff, just what you need to score. Part 2 Gynaecology is coming up next. So stay tuned, don't forget to like, subscribe and hit the bell icon so you don't miss it. And if you want the PDF of these notes, the link for that is given in the comment box below. Also, you can join my Telegram study preparation group. The link for that is also given in the comment box. So let's get started and crack the exam together. So first we will see the types of placenta. Here you can find it is a suction-tubed placenta. First one in this image is a suction-tubed placenta. Here only one cotyledon is present and one cotyledon is separated. Okay, this is due to the separation of the cotyledon. And what are the complications? It can be PPH, vasa previa and retained placenta. Next one is, this image is placenta bilobata. What happens here? Here the placenta has divided into two. Here the placenta has not divided. In suction-tubed, the cotyledon has separated. But in placenta bilobata, the placenta has divided into two parts. The third image you can see is the filamentous or the membranous placenta. What happens here? You can find this cord is attaching to the membranes. Instead of the placenta, it is attaching to the membranes. And in this image you can find this is a vasa previa. What is vasa previa? Means exposed blood vessels of the umbilical cord is covering the cervix. And what is the treatment of vasa previa? It is elective LSCS. And vasa previa we can diagnose on transvaginal sonography with the Doppler. And if painless vaginal blood is coming out, it is the fetus blood. Okay, if painless vaginal blood is coming out, no pain, only bleeding, then it is the fetus blood. What are the complications of this filamentous or membranous one? Okay, so vasa previa is one of the complications of the filamentous or membranous placenta, and also there can be fetal hemorrhage. Now, in twin pregnancy, you will not see this placenta bilobata or suction-tubed placenta. In twin pregnancy, what you will see? You will see two umbilical cords. Here, there are two placenta. Here, cotyledon is divided into two. But here, in twin pregnancy, you will notice two umbilical cords. Some one-liners. What is the qualitative test to differentiate feto-maternal hemorrhage? So how will you understand whether it is the fetal blood or the maternal blood? How will you differentiate in the feto-maternal hemorrhage? The qualitative test. So the qualitative test is AP test or the single alkaline denaturation test. What is the quantitative test to differentiate feto-maternal hemorrhage? It is the Kluwer-Bethke test or the acid elution test. Now, if the feto-maternal hemorrhage is less than 12 weeks, what we have to give? We have to give 50 micrograms of anti-D intramuscularly. If the feto-maternal hemorrhage is greater than 12 weeks, after 12 weeks, then we have to give 300 microgram of anti-D IM. Routine at Rh negative, if it is at 28 weeks, then how much anti-D we have to give? We have to give 300 microgram again anti-D. And post-delivery, if the baby's blood group is positive and DCT is negative, direct Coombs test is negative, then what we have to give? We have to give 300 microgram of anti-D within 72 hours. So that's the dosage of anti-D. You have to remember everything here. Now, these are the types of placenta previa. So here you can find this is the low-lying placenta. In the type 1, there are 4 types. Okay, in type 1, this is a low-lying placenta which is 2 centimeter, within 2 centimeter from this internal os, lying 2 centimeter from the internal os. The type 2 is the marginal placenta which is touching the internal os. Here it is touching the internal os. Type 3 is the placenta partial previa and type 4 is the complete previa. So these are the 4 types of placenta previa. What is trophotropism? So placenta can migrate upward with the growing uterus. Okay, so we have to repeat the USG at 32 weeks because when the uterus grows in size, the placenta will itself migrate upward. So that is called known as trophotropism. Now, this is an image of abruptio placenta. This one here you can find, this is the image of abruptio placenta, this placenta. So what's the difference between the placenta previa and abruptio placenta? How will you understand? The nature of bleeding in placenta previa will be painless. It will be causeless and recurrent and it is always revealed. But in abruptio placenta, the bleeding will be painful and it can either be revealed or concealed. Concealed means blood will be inside, which is known as the cavalier uterus. Okay, the blood in the placenta previa, the bleeding will be bright red in color, whereas in abruptio placentae it is dark colored, and it will always be out of proportion in concealed or mixed, out of proportion. Okay, now coming to this, what I am repeating is the important points. You can go through the table once, but what I am repeating and highlighted is the important point. So if you feel the uterus in placenta previa will be soft and relaxed, but in abruptio placenta it will be tense, tender and rigid. In placenta previa you will find stalwarthy sign, means when you compress the placenta, the fetal heart rate will increase. When you release the placenta, it will be normal again. And placentography ultrasound, if you do in placenta previa, you will find placenta in the lower segment, whereas in abruptio placenta there will be placenta in the upper segment. So that's the thing. Also, when you do vaginal examination, placenta felt on the lower segment in placenta previa, and abruptio placenta, placenta will not be felt. What is the management of abruptio placenta? You have to check the fetal status. If the fetus is alive and is in distress, then you have to do LSCS, lower segment cesarean section. If the fetus is alive and no distress is there, then you can do either vaginal delivery or augmentation. Now, after checking the fetal status, if the fetus is found to be dead, then what you have to do? You have to check the mother. If the mother has DIC, if the DIC is negative, then the mother doesn't have DIC, then you can either do vaginal delivery or augmentation. And if the mother DIC is positive, then you have to correct that DIC with the help of fresh frozen plasma. After correcting it with fresh frozen plasma, you can do vaginal delivery or augmentation. Okay. And what is the management of placenta previa? So if it is less than 37 weeks, fetal distress is negative, and the mother is stable, then we can do McAfee-Johnson regimen, which means we can give bed rest, tocolysis, wait and watch, and steroids. So that's the McAfee-Johnson regimen. If it is less than 37 weeks, fetal distress negative, mother is stable. And steroids, what you can give? Dexamethasone 6 mg, 4 doses, 12 hours apart intramuscularly, and betamethasone 12 mg, 2 doses, 24 hours apart intramuscularly. The contraindication for steroids is chorioamniotis. Okay. And if it is more than 37 weeks, then you have to do elective LSCS. So that's the thing here. The management of both placenta previa and abruptio placenta are done. Now, what is morbidly adhered placenta? So morbidly adhered placenta is due to the absence of the Nitabux layer or the decidua basalis. So here you can find this image. This is the normal presentation, first image. But this is the placenta accreta. So these are the types of morbidly adhered placenta. First one is placenta accreta, where the placenta is adherent to the myometrium, to the muscle layer. The placenta is adherent to the myometrium. Now, in the second one, the placenta increta, you can find the placenta now has invaded into the myometrium. The placenta has invaded into the myometrium. And in placenta percreta, what happens? The placenta now penetrates to the perimetrium, the outer layer. The placenta has penetrated to the perimetrium up to the serosa and is causing injury to the bladder. So the placenta may cause injury to the bladder. Okay. What is the treatment? You have to do the classical cesarean section. After that, you have to do fetal extraction, and then you can do cesarean hysterectomy. Okay, you have to do cesarean hysterectomy. Now, calculation of the expected delivery date you can do with the help of Nagel's formula. So what we have to do, you have to add 7 to the days and subtract 3 from the months. So whatever is the last menstrual period, suppose the last menstrual period is 10th of June 2025. So what we have to do according to Nagel's formula, you have to add 10th is a day of the June month. Okay, so you have to add 7 to days. So if you add 7 to 10, it is 17th. From the months June, you have to subtract 3 months. So if you subtract 3, it is March. So 17th of March, and it will be next year 2026. So the expected delivery date is 17th March 2026 if the last menstrual period is 10th June 2025. Now, there is one exception, like there is one condition here. If the month is changed while adding the days, you have to subtract 2 months, then not 3 months. Okay, 2 months. Like suppose the date is last menstrual period is 28th of June 2025. Now when you are adding the dates, it has gone to the next month, right? If you are adding 7, it has gone to July. It is not in June anymore. So what you are doing, you are adding 7 to the days. It is coming 5 of the next month. But here months you are not subtracting 2 because already it has gone to the next month. Therefore, you have to subtract 2 from it, not 3. So if you subtract 6 from that, you have to subtract 2. It will coming 4. So 5th of April 2026. So that's the thing. Now, if the cycle is irregular, you don't know the last menstrual period, unknown LMP, or if there is any failure of contraception, so what you have to do? So first trimester, you have to take the crown rump length. If it is in the second trimester, you can check the biparatal diameter to know the date. And in the third trimester, you can see the fetal length with the help of abdominal circumference. Also in the Nagel's formula, this formula was applicable for the 28 days cycle, okay, the 7 days and 3 months subtraction. If the cycle is prolonged, you have to add extra days, and if the cycle is short, if you have to subtract the days. So that's a common sense. If the cycle is long, you have to add the extra days. If the cycle is short, you have to subtract the days. And if the cycle is irregular or unknown LMP or failure of contraception, these are the methods by which you can identify, like get the expected date of delivery. Now, a question is there that the woman came to OPD with twin pregnancy. She had first trimester abortion 1 first trimester abortion. She has a 5-year-old child born at 9-month gestation. So how will you name it? It is G for P1, L1 and A1. G for gravid, P for para, and the A is the abortion. Okay. So that's the thing. You have to learn how to name it. Next is, which you can call preterm. Preterm is less than 37 weeks. Early term is 37 to 38 weeks plus 6 days. Midterm is 39 to 40 weeks plus 6 days. And you can do elective delivery in the midterm when it is 39 to 40 weeks plus 6 days. Late term is 41 to 42 weeks. What is postdatism? It is more than 40 weeks. Post-term, it is more than 42 weeks. Postdatism 40 weeks. Post-term more than 42 weeks. Now, what is the diagnostic criteria of preterm labor? So there should be 4 contractions in 20 minutes or 8 contractions in 60 minutes. Cervix along with that. So this is the first thing. Along with that, the cervix should be more than 2 cm dilated and 80% effaced. What is the predictor of preterm labor? On TVS, cervical length should be less than 2.5 cm and internal os diameter should be more than 8 mm. Fetal fibrinonectin between 20 to 34 weeks should be more than 50 nanogram per ml. How can you prevent preterm labor? By giving progesterone or doing cerclage. What is the most common cerclage done? It is the McDonald cerclage. And what are the contraindications of cerclage? You cannot do it if there is infection, membrane rupture and vasa or placenta previa. If the cerclage fails, what you can do? You can do the modified Shirodkar technique. And if that fails also, you can do the abdominal cerclage. What is the most common one? Benson and Durfee. Now, what is the management of preterm labor? So, high vaginal swab for group B streptococcus. If it is positive, first you have to check the group B streptococcus. For that, you have to take vaginal swab, high vaginal swab. And if it is coming positive, you have to give injection benzyl penicillin at the onset of labor. Why we are giving it? To prevent the neonatal meningitis. Benzyl penicillin is given to prevent neonatal meningitis. Now, if the gestation period is more than 34 weeks, we have to deliver the baby and we can give steroids till 36 weeks. And if it is less than 34 weeks, we can give tocolysis. The drug of choice is nifedipine. We can also give atosiban because nifedipine is contraindicated in cardiac patients. So we can give atosiban in cardiac patients. Along with that, we can give steroids, and magnesium sulfate can be given at 28 to 32 weeks. Now coming to post-term. So post-term, we can identify with the help of Bishop's score. So there should be dilatation, length, position, consistency, station of the fetal head. All this you have to calculate. And if the score is coming more than 8, so it is favorable for induction of labor. If the score is coming less than 5, it is the ripening of cervix. That means we have to give dinopristone. We have to ripen the cervix more. Bishop's score, you don't have to remember everything. You just have to know the name Bishop's score. Okay. And induction of labor, how can you do? The drug of choice for that is misoprostol. The dose is 50 to 100 microgram per oral and 25 to 50 microgram per vaginal. Every 4 hours, maximum 6 doses. Side effects for this are uterine rupture, and contraindication is previous LSCS. The contraindication of previous LSCS is only applicable when when we are giving misoprostol for the introduction of labor. Okay, induction of labor. Now coming to the folic acid, so vitamin B9. Folic acid is also known as vitamin B9. When we have to start 3 months prior and continue up to 14 weeks. Prophylactic dose is 400 microgram per day. Therapeutic dose is 4 milligram per day. And when you are giving the therapeutic dose, when there is any previous neural tube defects, family history of neural tube defects, thalassemia, or patient is on anti-epileptic. These are the ANC visit which is recommended by who recommends 8 ANC visit, India 4 ANC, and ideal it is 12 to 14 ANC visits. Now folic acid deficiency, if it is there, then we have to give 1 milligram per day folic acid. What is the dose for calcium? 1000 to 1200 milligram. Dose for vitamin D, 6000 international units per day. And what is the vaccination which is given in pregnancy? There are 2 doses of TD, 4 to 6 weeks apart, and if previous pregnancy was within 3 years, within the previous 3 years, we can give 1 single booster dose. Then 2 doses of TD are not required. It is TD, okay? And iron, regarding the iron, everything you can study from the PSM notes. We will discuss anemia later in this chapter, but you can study the iron from the PSM notes. I have told it there about pregnancy and iron. Next comes aneuploidy screening. So in the first trimester is 11 to 14 weeks. So that time you can screen aneuploidy with the help of double marker. Double marker means it includes beta HCG and PAP-A. Also you can use the combined method which includes double marker plus NT scan. Okay. And NT should be less than 3 millimeter. It is normal. If it is more than 3, it can indicate Down syndrome more than Turner syndrome. Okay. And on second trimester you can do 15, like it's in the 15 to 20 weeks, you can do the anomal scan for the nuchal fold thickness. If it is more than 6 millimeter, then we can do karyotyping. What is the quadruple marker? It includes beta HCG. A question can come from here. What is the quadruple marker? What are the components? It has beta HCG, unconjugated estriol, AFP, alpha fetoprotein, and inhibin A. In the option it can be given inhibin B or something. So you have to remember all these 4 components: beta HCG, unconjugated estriol, AFP, and inhibin A. Now miscarriage, so less than 24 weeks, and if it is less than 500 gram, it is known as miscarriage. Most common cause in the first trimester, it is genetic, and the autosomal trisomy, most common trisomy is 16. Most common risk factor is maternal age more than 35. Most common in the second trimester, most common cause is cervical incompetence. Most common single cause of recurrent miscarriage is APLA. And the treatment is low molecular weight heparin plus aspirin. APLA is antiphospholipid syndrome. We'll discuss it here, okay? But here you can see these are the prenatal examinations, and these are the weeks of pregnancy given here. So chorionic villus sampling, you can do it between 10 to 12 weeks. And what is the most common complication? It is abortion. Then you can do amniocentesis between 15 to 16 weeks, 14 to 16 weeks, okay? Chordocentesis at 20 weeks, like this. All the methods are given here, and the weeks are mentioned here. So in amniocentesis, what you are doing? You are taking the amniotic fluid and testing. In chordocentesis, what you are doing? You are taking the blood from the umbilical cord. And in chorionic villus sampling, you are taking from the chorion. So these are the parts from which the sample is taken, and at what weeks of pregnancy it is done. So this is the image. You can have a look at this image once. Now coming to the antiphospholipid syndrome. Okay. So what is the diagnostic criteria? So there should be more than 1 clinical criteria, and along with that more than 1 laboratory criteria. So these are the clinical criteria, 2 clinical criteria and 3 lab criteria. What are the clinical criteria? There should be more than 1 arterial, venous, or small vessel thrombosis event of any organ, or there should be pregnancy morbidity. It can be A, B, or C. In A, there is more than 1 unexplained fetal death at 10 weeks of gestation, more than 1 premature birth before 34 weeks of gestation, and more than 3 consecutive spontaneous abortions before the 10th week. So these are the clinical criteria. There should be more than 1. And laboratory criteria are lupus anticoagulant positive, IgM or IgG anticardiolipin antibodies should be positive on more than 2 occasions, more than 12 weeks apart, and IgG or IgM anti-beta-2 glycoprotein antibody should be in moderate or high titers on more than 2 occasions, more than 2 weeks apart. So these are the lab criteria, and 1 clinical criteria and 1 lab criteria should be present. Now this is the abortion. So these are the various types of abortion. This is threatened abortion. So here you can find what are the uterus sizes in the various types of abortion. In threatened abortion, uterus equals to the period of gestation. In inevitable, you will find uterus again equals to the period of gestation. Incomplete, okay, uterus is less than the period of gestation. Complete, uterus less than the period of gestation. And missed, uterus again less than period of gestation. And in complete, what you will find, the pain and bleeding has decreased because all the matter has come out. Therefore, pain and bleeding will decrease. And in the rest, threatened, inevitable, and incomplete, you will find that there is pain, bleeding, and amenorrhea. And cervical os, it will be open in inevitable abortion and incomplete abortion. So all the abortion which is starting with I, you will find that the os will be open. All others, the os is closed. By that you can remember it. Fetal cardiac activity is present in threatened abortion, so you can give reassurance. And in inevitable abortion, it can either be present or absent. And what is the treatment? What is the management? Medical termination of pregnancy, MTP. Incomplete, no heartbeat. Complete, no heartbeat. Missed, no cardiac activity. In incomplete, you are doing medical termination of pregnancy. Incomplete, we are giving antibiotics because already the matter has come out. And in missed, what we are doing? We are doing MTP plus we are also seeing for the fetal cardiac activity, we are also seeing the USG. The crown rump length should be more than 7 millimeter, and mean sac diameter should be more than 25 millimeter, and no embryo should be present. There should be, that is, it is a blighted ovum. On USG, the following finding will be noticed. So what is, like, when can we do the medical termination of pregnancy? When there are victims of rape or change in marital status. Suppose the lady was pregnant and after that the husband has died, so that is change in marital status. So we can do it at 24 weeks. If there is a contraception failure, it is at 20 weeks. And lethal anomalies, there is no upper limit. We can do the medical termination of pregnancy at any time. And who will decide that? There should be a board which consists of a pediatrician, obstetrician, sonologist, and the members from the state government. Up to 20 weeks, only one doctor opinion is okay. At 20 to 24 weeks, 2 doctors are needed. And who can give the consent? Only woman consent is enough. No husband is needed, nothing is needed, okay? And if it is less than 18 years case, then we have to first inform the police, then we have to take the guardian consent. Then the woman cannot give the consent. Now, what are the drugs by which we can do the medical termination of pregnancy? So in the first trimester, we can give mifepristone 200 milligram orally. After 24 hours, we can give misoprostol 800 microgram PV or sublingually or buccal. Then, or we can give misoprostol alone. What is the dose if we give misoprostol alone? 800 microgram, repeat every 3 hours for 3 doses. Second trimester, what we can give? Mifepristone 200 milligram orally. After 24 hours, we can give misoprostol 400 microgram every 3 hours for 5 doses. And if we give misoprostol alone, it is 400 microgram every 3 hours, 5 doses. And dinoprostone can be given 20 milligram in suppository every 4 hours. Now these are the instruments. So these are the surgical methods of abortion. First one is the menstrual regulation syringe. These images can come in your exam. Menstrual regulation syringe is always requiring a Karman's cannula. So a Karman's cannula is attached to it. It is a 50 ml syringe and it can be used up to 6 weeks. The second one is the manual vacuum aspirator. Again, it requires a Karman cannula. The size of the Karman cannula should be size equals to gestational age in weeks in even numbers. Suppose the gestational age is 10 weeks, then we have to use the 10 size Karman cannula. Now, if the gestational age is again 11 weeks, we have to use the 12 size or the 10 size, okay, even numbers. Now, the volume, like the ml of the syringe is 60 ml and its pressure is 660 mmHg. It can be used up to 12 weeks. Menstrual regulation syringe up to 6 weeks. Manual vacuum aspirator up to 12 weeks. This one is the suction and evacuation machine. So the pressure here is 600 mmHg and it can be used up to 12 weeks. Here, this is the ovum forceps for dilatation and evacuation. This one is the ovum forceps. And fifth, we can do the hysterectomy. Surgical methods of abortion. Now, so this topic is completed. Our next topic is ectopic pregnancy. So what is the most common cause? It is PID, pelvic inflammatory disease, more than previous ectopic cases. What is the most common site? It is the fallopian tube. Among the fallopian tube, it is most common in ampulla and least common in interstitial. Earliest to rupture and the most common to rupture is the isthmus, and least to rupture is the interstitial. Here you can find what are isthmus, interstitial, etc. So interstitial is the least to rupture, and ampullary you can find it is the most common, 70%, and these are the various places of ectopic pregnancy. Unruptured ectopic, okay, unruptured ectopic, the ectopic has not ruptured. What you can do, like investigation of choice for that is transvaginal sonography. What you will see is G-sac in the fallopian tube, which is known as the Begel sign, and on Doppler you will find a ring of fire appearance, this one, ring of fire appearance for unruptured ectopic. What is the gold standard? We have to do it laparoscopy. Now, management for ectopic pregnancy, medical management includes methotrexate 50 milligram per meter square intramuscularly. And the sac size for that should be less than 4 centimeter. Fetal heart rate should be absent. Beta HCG should be less than 5000 international units per liter. Then we have to check the beta HCG day 2, day 4 and day 7. If there is drop from 15% of the previous beta HCG, then it is responding. Okay, the treatment is responding. And if the drop is less than 15%, we have to repeat the dose again. Repeat the dose of methotrexate again. Maximum 3 doses we can give. Surgical methods, if the sac is more than 4 centimeters. So these are the indications for surgery. We can do surgery if the sac is more than 4 centimeter plus fetal heart rate is present and beta HCG is greater than 5000 international units per liter. So what are the surgical methods? Salpingectomy, salpingotomy, salpingostomy. Okay. If there is ectopic like abdominal pregnancy, it is done by Stodiford criteria. You just have to remember the names of the criteria. Ovarian pregnancy, Spiegelberg criteria. Cervical pregnancy, Rubin's criteria. What is a ruptured pregnancy? What will be the symptoms? There will be amenorrhea, abdominal pain. Per abdomen it should be tense, tender, rigid. We will find Cullen sign like the bluish discoloration at the umbilicus, great ulnar sign, bluish discoloration at the flanks. Okay. And per vaginally, what we will notice, there will be cervical motion tenderness will be positive. Also, there will be fullness in the pouch of Douglas. And what is the treatment? Immediate laparotomy plus salpingectomy. So this is the image of molar pregnancy, complete molar pregnancy. Okay. And what are the clinical features of molar pregnancy? We will find amenorrhea, bleeding per vagina, abdominal pain, and passage of grape-like vesicles. So that's the difference between complete and partial mole. Uterus will be more than the period of gestation in complete mole. In partial mole, uterus will be less or equal to the period of gestation. The uterus in complete mole will be soft and doughy in texture. In partial mole, it will be the fetus will be present, and in complete mole there will be no fetus. What is the investigation of choice for molar pregnancy? TVS, and it will show this one, snowstorm appearance. What are the complications of molar pregnancy? There will be hyperemesis gravidarum, early onset preeclampsia, bilateral thecal cyst, thyrotoxicosis, pulmonary embolism, and choriocarcinoma. What is the treatment? Suction and evacuation. If the woman's age is more than 40 years plus family is already completed, if the woman agrees, we can do the hysterectomy. What is the contraception of choice after doing this surgery? It should be combined oral contraceptive pills or condoms. Now, again a new topic, which is hypertension in pregnancy, a very important topic. So what's the definition of gestational hypertension? Like when the woman develops hypertension after 20 weeks of pregnancy and it will resolve after delivery. Okay, so during the period of gestation, the woman has developed this hypertension. It was not from previous. What will be the clinical features? There will be headache, vomiting, pulmonary edema, reversible blurring of vision, epigastric pain, increased LFT or oliguria. What is chronic hypertension? If there is high blood pressure diagnosed before pregnancy, okay, before the pregnancy only hypertension was there and it was before 20 weeks of gestation. Preeclampsia, it is a severe form of gestational hypertension that includes high blood pressure and signs with damage to the other organs. So there will be end organ damage in preeclampsia like the kidneys or liver. There will be headache, blood vision, etc. And preeclampsia is again of two types, mild and severe. Mild means less than 160 by 110 and there is no end organ damage. Severe is more than 160 by 110 plus damage. What is eclampsia? Preeclampsia plus seizures. Okay, if there is seizure present, it is eclampsia. What is the prevention of preeclampsia? We have to give aspirin plus calcium if there is deficiency of calcium. And management for gestational hypertension, deliver at 39 weeks. For mild preeclampsia, deliver at 37 weeks. For severe, deliver at 34 weeks. And severe with impending signs, then we have to deliver immediately. Plus we have to give magnesium sulfate prophylaxis. So this is the umbilical artery velocimetry. This question has come in the January exam also, FMG. So this velocimetry is done to check the fetal well-being. So here you can find this is the decreased end diastolic flow. So this is the systolic and diastolic. Okay, so here you can find decreased end diastolic flow. Here it is absent end diastolic flow, and here it is reversed end diastolic flow. So if there is decreased end diastolic flow, what you have to do? You have to deliver at 37 weeks. If there is absent end diastolic flow, you have to deliver at 34 weeks, and reversed end deliver at 30 to 32 weeks. What is the predictor? There should be persistent of diastolic notch up to 20 to 24 weeks, and mean arterial pressure should be more than 90 mm of Hg. What is the treatment? Drug of choice is labetalol, like for this. Okay, for the preeclampsia treatment is drug of choice is labetalol, but labetalol is contraindicated in asthma. We can give alpha methyl dopa, nifedipine and hydralazine. What is contraindicated? So it is contraindicated in like what are the drugs which are contraindicated? Okay, so contraindicated are SE inhibitors, angiotensin receptor blockers, and diuretics. And labetalol is contraindicated in asthma. Again, our new topic is diabetes. So most common congenital malformation for overt is ventricular septal defect, and that after that is neural tube defects. What is the difference between overt diabetes and gestational diabetes mellitus? So overt means during the pregnancy only the woman has developed diabetes, glucose intolerance, and gestational means before the pregnancy also there was diabetes present in the woman. So overt, what are the criteria? The fasting blood sugar should be more than 126 milligram per deciliter, postprandial more than 200, and HbA1c more than 6.5. What is the most specific congenital malformation? It is sacral agenesis, and most specific cardial malformation, it is the transposition of great arteries. Fetal echo should be done at 18 to 20 weeks of gestation. Drug of choice for diabetes, overt diabetes, is insulin. Now coming to gestational diabetes mellitus, all women, like it is an universal screening at first visit should be done. Then we should repeat the screening at 24 to 20 weeks to diagnose diabetes. And how will you do the screening? 75 gram of oral glucose tolerance test is done. Earlier 100 was done, but now 75 gram. And fasting level should be less than 92, 1 hour should be less than 180, and 2 hours should be less than 153. So 92, 180, 153 values you have to remember. What is the management? First, you have to change the diet and do exercise. If after 2 weeks it does not resolve, the diabetes does not resolve, we have to give insulin. Insulin is the drug of choice. We can also give metformin. And what is our target? Fasting blood sugar should be less than 95. Postprandial should be less at 2 hours. Postprandial 2 hours should be less than 120. Weight of the baby, if it is more than 4 kg, what we are doing? We are doing LSCS. If the gestational diabetes mellitus or overt diabetes is controlled on diet, then we can deliver at 40 weeks. If the gestational diabetes mellitus or overt diabetes is well controlled on medication, after giving these drugs, insulin, metformin, it is controlled, then we can deliver at 39 to 39 plus 6 weeks. And if it is poorly controlled on medication, we can deliver at 37 weeks. If it is not controlled, we can deliver at 34 weeks. What is shoulder dystocia? So shoulder dystocia question has already come in the January exam. It is again important. If the head to body delivery time is more than 60 seconds, it is shoulder dystocia. So that's the definition. What is the management? Mac-Roberts maneuver. If it fails, we have to give the suprapubic pressure. If it fails, we have to give Wood corkscrew method. All these methods you have to remember. The definition, the process you don't have to know, only the names, okay? And if the Wood corkscrew method fails, we have to give posterior arm extraction. If it fails, then we have to position the mother in all four, okay? Like a cat or dog, or which is known as the Gaskin position. If it fails, then we have to break the clavicle of the baby and deliver. Break the clavicle, so that is known as fetal cladotomy. Next, a short important topic about the cardiovascular thing. So if there is atrial fibrillation or prosthetic valves in the mother, we have to give warfarin therapy, and the dose should be, if it is less than 5 milligram per day, then we can continue the warfarin till 36 weeks. If it is more than 5 milligram per day, so it is teratogenic, right? So it can cause cleft lip, cleft palate, all these things. So in the first trimester, we have to convert the warfarin to low molecular weight heparin. We have to change it to low molecular weight heparin. In the second and third trimester, we can convert it back to warfarin. And at 36 weeks, we can convert it back to low molecular weight heparin. So what we have to do after converting it to low molecular weight heparin, so we have to stop it 6 hours prior to the delivery. Before the delivery 6 hours, we have to stop this low molecular weight heparin. And after the delivery, we can give warfarin plus unfractionated heparin together. When the INR of 2.5 to 3 is attached, is reached, we can stop the heparin. Only warfarin is continued. So this is very, very important. You have to just remember this flowchart. It is given in the very easy form, in the form of a flowchart. Just remember this flowchart. A sure short question will come from here. Question will come from here. All which I am like describing in this PDF. Okay. Because this means all these are previous year topics, previous year questions. Very, very important. You cannot miss anything in these notes. If you revise this 2 to 3 times, you can attempt more than 90% questions in your FMG and even PG exam. Both in FMG and PG exam, you can get more than 90% questions and even more than 95% questions. Like the rest 5%, no one knows what question will come. But if you revise these notes, only 4 pages are there, okay? If you revise this obstetrics note, and next I will begin, like I will come with gynecology. So total there will be 8 to 9 and even 10 pages. So if you revise this 8-9 pages at least 2 times before the exam, and you can even carry to your exam center, like to your exam city. You are moving 1 to 2 days before, right? So you can carry this small notes PDF to your exam city, and if you revise this 2 times, then you will get more than 95% in your exam. The strike rate will be more than 95%. Anemia, when we can call it an anemia, so anemia can be mild, moderate and severe. If it is 10 to 10.9 gram per deciliter, it is mild anemia. If it is 7 to 9.9 gram per deciliter, it is moderate, and severe is less than 7. So in mild to moderate anemia, if it is less than 34 weeks, we have to give 2 tablets of oral iron till the hemoglobin improves, then 1 tablet per day. If it is more than 34 weeks, we have to give parenteral iron. And what is parenteral iron? Iron sucrose 200 milligram IV. If it is severe anemia less than 5 gram per deciliter, then packed cell transfusion. If it is 5 to 6.9, okay, 7 is severe. If it is 5 to 6.9, if it is less than 34 weeks, parenteral iron, more than 34 weeks, packed cell transfusion. So here this is an image of twin pregnancy, dizygotic twin, dizygotic. So in dizygotic twinning, you can find dichorionic and diamniotic. So there will be 2 chorion, 2 amnion here. But question will come from monozygotic twinning. Monozygotic, it depends what type of twins. There are 3 types: dichorionic diamniotic, monochorionic diamniotic, and monochorionic monoamniotic. So here it depends on the splitting of the morula. If the morula splitting is within 72 hours, okay, in 3 days, then what happens? You will find that this one, dichorionic diamniotic, will be formed. 2 chorions, 2 amnions, and you have to deliver at 37-38 weeks. On USG, you will find lambda sign or the twin peak sign. So this is the lambda sign or the twin peak sign. Okay. This is for dichorionic diamniotic. If the morula splits at day 4 to day 8, so what you will find here, you can find that there is a same placenta. This placenta is same, but the amniotic sac is different. There are 2 amniotic sacs, but the placenta is same. So monochorionic but diamniotic. Here both the placenta, 1 placenta, 2 placenta, 1 amniotic sac, 2 amniotic sac. Here only 1 placenta, but 1 and 2 amniotic sacs. Here you can deliver at 36 to 37 weeks, and here you will find a T sign. You can find this is the T sign. Okay, this is the T sign. And the third one is the monochorionic monoamniotic. If the morula splitting is at 13 to 15 weeks after the implantation happens, then there will be single placenta, single sac. There is no double sac, no space in between, no gap, like no division in between. Here only 1 placenta is there and only 1 amniotic sac is there. So single placenta, single sac, deliver at 30 to 34 weeks using LSCS and after giving steroids. What is superfecundation? If the fertilization of 2 ovaries in the same cycle happens but by 2 different acts of coitus. So that is superfecundation. Superfecundation not possible in humans, so I am not discussing. Here you can find that this is the twin to twin transfusion syndrome. So what happens? This is found in monochorionic and diamniotic twins. If the placenta is same, chorion is the same, and diamniotic, 2 amniotic spaces are there, then it happens twin to twin transfusion syndrome. There are 2 twins. One is the recipient one, where you can find polycythemia, polyhydramnios, and this is the donor one. This will not survive. Here you can find anemia and oligohydramnios. What is the treatment? We can do fetoscopic laser ablation of AV malformation. Delivery, first the vertex. If first twin vertex is there, we have to do vaginal delivery. If first twin is non-vertex, then we have to do cesarean. If the second twin is breech, we have to do assisted vaginal delivery, breech. And if the second twin is transverse lie, then we can do internal podalic version plus breech extraction. Question will come from here. Okay. Then you can find the various positions, like this is the right occiput anterior. So how will you understand left, your right, like you are facing the paper, you are facing the computer screen, okay, while giving the exam. So your right will be the patient's left, your left will be the patient's right. This is one thing. And second is, if the presenting part is towards the symphysis, it is the anterior, and if it's towards the sacral promontory, it is the posterior one. So by this you can name it if it comes in the exam. Like here you can find the mentum, the face is presenting here. Okay, so it is left mentum anterior. So like that you have to name it. These are the labors. So various the Leopold maneuvers for labor. Here you can find the first maneuver is the fundal grip. First, second and third maneuver. Okay, the first, second and the third Leopold maneuver, you are facing to the face of the patient, and in the fourth one you are facing to the feet of the patient. Okay, you are standing at the head. So while doing the fundal grip, if you are finding it soft, broad and irregular, if you are feeling it soft, broad and irregular, it is the buttocks. If it is hard and curved, it is the head. The second one, you have, this is the lateral grip, you have to place it here. So lateral grip, if it is smooth and curvilinear, this one, then it is the back. The third grip is known, the third maneuver is known as the Paulick's grip. What you are doing, if you are touching the presenting part, and if it is presenting part is moving, means it is not engaged. If the presenting part is not moving, it is engaged. And the fourth Leopold maneuver is the pelvic grip. You are standing at the head and facing the feet of the patient, and if both the hands of both the hands of the doctor here converge, that means it is not engaged. If it is diverging, it is engaged, and it tells us about the descent and the attitude of the fetal head. So next one is the inferior vena cava syndrome, or the supine vena cava syndrome, not superior vena cava, supine vena cava. Okay, what happens when a pregnant woman lies flat on her back? It causes the enlarged uterus. You can find the enlarged uterus will compress the inferior vena cava. So this blue one is the inferior vena cava. The uterus is compressing the inferior vena cava and the aorta. This will reduce the venous return to the heart and can lead to drop in the blood pressure, which will cause dizziness, nausea, and even loss of consciousness. So these are the types of pelvis according to the Caldwell and Molloy classification. The first one is the gynecoid pelvis, most common. Here you can find round one. If the transverse diameter, this diameter is more than the anterior posterior diameter, okay, then it is the platypeloid pelvis. It is the least common one. Android pelvis, heart shaped like the male pelvis. And anthropoid, you can find it from the name only, AP. So anthropoid, here the anterior posterior diameter is more than the transverse diameter. So these are the types of pelvis. Here you can find true conjugate, obstetric conjugate, and diagonal conjugate. So what is diagonal conjugate? This one, okay, this line, the line I am marking with red. So it is attaching from the lower border of pubic symphysis. The lower border of pubic symphysis is here to the sacral promontory, and its length is 12 centimeter. Obstetric conjugate, the next one, it is attaching from the posterior surface of the pubic symphysis to the sacral promontory, and it is 10.5 centimeter. And the true conjugate, this one, the first line, it is attaching from the upper border of the pubic symphysis to the sacral promontory. This is the upper border, so it is 11 centimeter. Contracted pelvis, like if the obstetric conjugate is less than 10 centimeter, this one, or if the transverse diameter is less than 12 centimeter, then we can call it a contracted pelvis, and the management is lower segment cesarean section. These are the cardinal movements of labor. So engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. In engagement, if the biparietal diameter passes through the pelvic brim, this is known as engagement. Descent means going down. The ischial spine is considered as the zero station. Above it, 1, 2, 3, plus 1, 2, plus 2, plus 3, like this the station increases. And if it goes below, it is -1, -2, -3. What is internal rotation? Like when the occiput rotates to come below the pubic symphysis, it is the internal rotation. Next, we will look at the stages of labor. Very, very important. So there are 4 stages of labor. The first stage is divided into latent and active. Latent phase, there is 0 to 4 centimeter. Active phase is 5 to 10 centimeter. The latent phase is again divided into active and prolonged. So in primary gravida, it is 10 to 12 hours. Active phase, and multigravida 6 to 8 hours. The prolonged phase in primary gravida is more than 20 hours, and multigravida is more than 14 hours. In active phase of the first stage, the rate of dilatation in primary gravida is 1 to 2 centimeter per hour, multi 1.5 centimeter per hour. Rate of descent, primary gravida 1 centimeter per hour, multigravida 2 centimeter per hour. So we have to check the contractions. If inadequate contractions are there, we have to do augmentation of labor using oxytocin. If adequate, we have to check with PV. Okay. What do you mean by adequate contractions? It means there should be 3 contractions in 10 minutes for more than 10 seconds. Now, what is active phase arrest? So active phase arrest means cervical diameter is more than 6 centimeter dilated. So it should be 5 to 10 centimeter, right? It is more than 6 centimeter dilated, membranes are absent, and adequate contractions are there, but no dilatation for 4 hours. And if there are any inadequate contractions, there is no dilatation for 6 hours, then we have to give oxytocin. And what is the management? Lower segment cesarean section. What is arrest of descent? No descent for 1 hour. Protracted descent less than 1 centimeter per hour. Here the descent should be 1 centimeter per hour in primary gravida, but here it is less than 1 centimeter per hour. It is protracted descent. Now coming to the second stage of labor. So In primary gravida, the second stage of labor, average is 1 hour, prolonged is more than 2 hours, arrest is more than 3 hours. In multigravida, average is 30 minutes, prolonged means more than 1 hour, arrest is 2 hours. Sorry. Delivery, Ridgen's maneuver, you can do Ridgen's maneuver in average, normal one. And in the prolonged and arrest thing, we have to check the station of fetal head. If it is above +2, then we have to do LSCS. If it is at +2 or below +2, we have to do instrumental delivery. Then comes the third stage, and here you have to remember the active management of the third stage of labor, AMTSL. Okay, this will come in the question. What you have to do? We have to immediately administer ureterotonic drug. What is the ureterotonic drug? We can give oxytocin 10 international units IM or IV drip, or we can give misoprostol also 600 microgram per rectal. Then we have to do delayed cord clamping, means at 1 to 3 minutes, and controlled cord traction, then intermittent uterine tone assessment by doing uterine massage. What are the indications for early cord clamping? If there is fetal distress or internal uterine growth restriction, if it is Rh negative or mother is unstable or placenta previa is there, we can do early cord clamping. But in third stage of labor, active management, we are doing delayed cord clamping. Okay. Here are the images of various breech, frank breech. In frank breech, what you will find, it is also known as extended breech. Here you will find the legs will be extended and buttocks will be here. Okay, only the buttocks are coming out. So it is the best for vaginal delivery. In complete breech, both the legs and buttocks are present here. In footling breech, only one foot has come out. We have to do LSCS here, and there is risk for cord prolapse in footling breech. Incidence of breech at 28 weeks is 20%, but at 40 weeks it reduces to 4%. Why? Because when the uterus grows, the baby can, like the breech can automatically dissolve on its own. So we have to wait up to 36 weeks. If at 36 weeks also breech presents, then we have to rotate the baby by our own. How you can rotate? By doing external cephalic version. So this is the external cephalic version procedure. You just have to know the name, that we can do external cephalic version at 36 weeks. What are the contraindications? So absolute contraindication for external cephalic version is the placenta previa. What are the relative contraindications? Early labor, oligo or polyhydramnios, IUGR, rupture of membranes. What is the complication of external cephalic version? Cord entanglement or fetal distress. And delivery, how you can do? By the maneuvers like Burn Marshall maneuver, Pinard's maneuver, Lovesets maneuver. You can watch the videos of this from YouTube, but now it's not necessary. You don't have to know the names of the maneuvers. Okay, Burn Marshall, Pinard's, and Lovesets. Here you can find Piper forceps. This is the image. Okay, if we have to use forceps, this is the Piper forceps. Now, coming to our last topic of obstetrics, the postpartum hemorrhage. So postpartum hemorrhage is what? It is the excessive bleeding after the birth of a baby. It is one of the leading cause of maternal morbidity. What are the types? Primary and secondary. So primary is early if it occurs within the first 24 hours of delivery, and secondary means between 24 hours to 6 weeks after delivery, postpartum. And what is the definition? If the blood loss is more than 500 ml after vaginal delivery or more than 1000 ml after cesarean section, or any blood loss which is causing hemodynamic instability. The causes are the 4 T you can remember: tone, tissue, trauma, and thrombin. Tone means there is uterine atony. Tissue, there can be retained placental tissue which is causing the hemorrhage. Trauma means any injury to the genital tract. Thrombin, there can be coagulopathy. What are the risk factors? Prolonged labor or very rapid labor, multiple gestation, polyhydramnios, previous postpartum hemorrhage, any operative delivery using forceps, vacuum, cesarean, placenta previa or abruption, high parity, or uterine overdistension. How will you manage? So medical management. First, this is the management steps. First step is the ABC approach, airway, breathing, circulation. We have to start the resuscitation. Then we have to administer oxygen, establish large bore IV access. We can give IV like the fluid resuscitation using crystalloids and blood products. Then we have to check the uterine tone. For that we have to do uterine massage. We can give ureterotonics like the oxytocin is the first line. We can give ergometrin, carboprost. We have to avoid it in asthma. Ergometrin avoided in hypertension. Misoprostol, oral or rectal we can give. Then you have to look for the retained tissue. If there is any remain of placenta there, then you have to manually remove the placenta, and evacuation should be done under ultrasound guidance if necessary. Then for trauma, we have to inspect the birth canal for laceration. Surgical repair is needed. Then we have to do. And if there is thrombin disorders, let me highlight this. If there are thrombin disorders, if there are thrombin disorders, we have to correct the coagulopathy, and we can correct it using fresh frozen plasma, platelets, and cryoprecipitate as needed. What are the surgical managements for the postpartum hemorrhage? Uterine tamponade using Bakri balloon. Okay, uterine artery ligation, B-Lynch suture, and hysterectomy is the last resort. So that's the end to our obstetrics ultra rapid revision. It is covered in 4 to 5 pages. You have to revise this at least 3 times. If you need the PDF, the link for the PDF is given in the comment box. You can follow me here on Instagram. You can put down your feedback in the comment box. It's very important for me. It will help me improve. And the next gynecology part 2 is coming maybe tomorrow. Okay, stay tuned. Thank you.